everyone, to our 6th annual acknowledgement or celebration of World Sickle Cell Day. We are very excited to have such a great turnout, so thank you for coming. And we have many things planned for you today. As you may know or have you seen at this point, this is also part of a larger campaign called the Shine the Light on Sickle Cell campaign, which was really literally a groundswell from the community. So several community-based organizations in sickle cell disease wanted to raise just the awareness of sickle cell and thought to come up with this campaign. And it just coordinated with the 10th anniversary of the United Nations declaring June 19th as World Sickle Cell Day. And so with that, we thought we would really try to, thank you. With that, we thought we would try to really raise the awareness internationally of World Sickle Cell Day and what it means. And so as well as in addition to the program occurring here, there are programs happening in Baltimore and Philadelphia, all along this coast, in Australia, in Jamaica. So we really are spreading this word. And so with that, we need your help. So please, 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 on your social media, please hashtag Shine the Light on Sickle Cell as we really try to spread this word, and we look to even make it bigger next year. So with that, we will begin our program. We will start with an invocation by Dr. Cicely Chisholm. She has a master's in divinity and is part of our pastoral care services team here at Howard University Hospital. Following her will be welcoming remarks by Dr. James Taylor, who is our director of the Howard University Center for Sickle Cell Disease. Enjoy.
Let us pray. Almighty God, we thank you for your guidance and direction in bringing us together as participants in this conference. We thank you for those in research who is opening the doors for more aggressive treatment outcomes in sickle cell disease. We pray for all those who will speak and ask that their contributions will be accepted and it will have a major impact. We ask that you will guide both contributors and patients and parents of children, making this effort one which will have considerable impact. May God bless you. Amen.
Well, welcome. Welcome, and thank you for coming today. So today we're going to be following up on last year's event that focused on legislative advocacy. We had members of the Senate and the House of Representatives here to talk about legislation and its history in sickle cell disease. Now we're doing the flip on that and following up on a press release from the U.S. federal government last September focusing on a cure for sickle cell and curing sickle cell now, and focusing on patient engagement. So this is at Howard University. This is part of our CHARM program. This is a federal grant that we've held for the last 5 years. The Center for Hemoglobinopathy Research in Minorities. We provide sickle cell trait screening with this funding. We've funded young investigators and pilot projects, and we have investigator level projects that focus on iron overload, HIV, and sickle cell disease. And has also funded myself as a new director. And since I've been here, we've been looking closely at our clinic. We've increased patient volumes by 15%. The hospital sees 100 admissions for sickle cell complications a month. And we follow currently 355 patients, and I've seen 30 new patients on top of that this year. So we are growing. So I just wanted to set the stage for what sickle cell disease is and what its impact is. Currently, we only have 2 FDA-approved drugs. There are 36 for hemophilia, 39 for HIV, and 8 for cystic fibrosis. This is a disparity of unbound proportions. 90% of hospitalizations for sickle cell disease are for pain, and for those of you who haven't seen a sickle cell pain crisis, it's excruciating pain. It's got to be comparable to a compound fracture of a major bone. It affects, as far as we can tell, about 100,000 patients in the U.S. When you're hospitalized for a sickle cell complication, the 30-day rehospitalization rate is 40%. That's the highest of any disease. And to add insult to injury, when you're rehospitalized, we don't get paid for doing our work. $1 billion or more in healthcare costs. Suboptimal adult care, and that's one thing I'm going to focus on. There's been no change in the mortality for adults in the last 30 years. They have poor access to care. There are too few physicians trained to take care of this disease. There are few incentives for hospitals to invest in the care of these patients. 20% of sickle cell disease patients have no FDA-approved drug to treat their disease. So I'm treating the symptoms, and I tell them this bluntly. These are the patients with hemoglobin SC and sickle beta plus thalassemia. There's poor implementation of curative therapy in terms of bone marrow transplant. That's the curative therapy. In the last 20 years, in the last 10 years, there have been about 115 bone marrow transplants for children with sickle cell disease. There have been about 100 for beta thalassemia major. The difference is there are 100,000 sickle cell patients in the U.S. There are between 1,000 and 2,000 beta thalassemia major patients in the U.S. So again, that's the disparity. We're not even offering the curative treatment to patients who are eligible. And there's been no consolidated effort for a cure, and this is a quote from myself. Even if we have the cure today, we don't even have the physicians to implement curative treatments. So just in terms of the history of sickle cell disease, is first described in the medical literature in 1910 by a man named James B. Herrick. Did a wonderful job describing the clinical manifestations in a dental student from Grenada in Chicago. In 1949, sickle cell really came into focus and center of attention when Linus Pauling, who won a Nobel Prize for describing the alpha helix of proteins, described sickle hemoglobin using starch electrophoresis, and a technique that we still use today to diagnose the disease, but he coined the term a molecular disease. And this is where we all learn about it in biology in the first week of medical school. It's July, almost July, so I give the sickle cell and protein lectures in biochemistry to first-year medical students. The reason we do that is because of Linus Pauling. We can look at the mutation, where it is, and predict what the protein's going to do and how the disease will affect you. So that's why science fell in love with this disease. Molecular medicine refined, we know the molecular mechanism, great science lauded to explain the disease pathophysiology. But in this era between 1949 and 1972, there was absolutely no clinical research focused on patients, not even the natural history. How long do people live? How many people have it? And certainly no treatment. Until 1972, when this man came along, Roland B. Scott was, in my estimation, a real hero in medicine. He was involved behind the scenes politically with the Nixon administration in crafting the language and the outlook for the National Sickle Cell Control Act. It was signed into law on May 16, 1972. At the time, so the Sickle Cell Control Act, we had 25,000 to 50,000 estimated patients in the U.S. Now we have 100,000. So it didn't do much to control the disease. Roland B. Scott published his first paper on sickle cell disease in children in 1948 and was a strong proponent of newborn screening, which is why children are identified early and really do very well in terms of their treatment. It wasn't until 1998 that the first FDA-approved medication for sickle cell disease came along, hydroxyurea. Last summer, or 2 summers ago, 2017, a drug called L-glutamine, which is an antioxidant. There's a lot of oxidative stress in red cells. Oxygen, water, and iron together create rust. That's called oxidation. This inhibits that reaction, and it does have a clinical effect. The only trouble is nobody wants to pay for it. It's too expensive. So treatment disparity. So we only have the 2 FDA-approved drugs. We're treating the symptoms with opioids. We're in the middle of an opioid crisis, and addiction happens in sickle cell disease. It's not a prominent feature, but it does happen. Nobody thinks about it. Transfusion therapy, in my opinion, is underutilized, although it has some complications. Bone marrow transplantation, you have to ask, do you have a brother or sister from the same parents? Could they be a match? Nobody's asking those questions. So only 1% of sickle cell disease patients are actually transplanted. Hydroxyurea and L-glutamine prevent painful episodes and hospitalizations. In Washington, D.C., only 16% of 600 adults actually get the medication. How do I know this? I was one of the top prescribers, and it was called down to the D.C. Department of Health to find out why more people don't get it. Annual costs, at least for D.C. Medicaid, $120,000 a patient, $71 million a year. Most of it spent in the hospital in the emergency room, which in my estimation is the wrong place to spend it. You spend it in the clinic to keep people out of the hospital. Just taking those numbers and doing some math on 100,000 patients, assuming just for adults that 60% of them are adults, 60,000 patients, 75% of those would have the worst form of the disease, sickle cell anemia or SS. That's 45,000 patients times $120,000 a year. On average, that's $5.4 billion annually. And this may be an underestimate. So where do patients receive care? Well, you go to a children's hospital when you're young and you get great care. And that's, again, a compliment to Roland B. Scott and newborn screening. And we really implement hydroxyurea and stroke treatment and stroke prevention early on. But what happens when you turn 18, you become an adult? I'm a pediatric hematologist who's migrated into adult hematology because there's a void to fill here. There's nobody to take care of these patients. Adult care, there's no central location. Nobody tells you where to go. Patients have a hard time finding good care. This has been highlighted in 2016 in the Washington Post. Poor incentives for adult care. Most of the patients who have the worst forms of the disease can't work. If you can't work, you don't have health insurance. That means you're on Medicare and Medicaid. That means that you get paid less if you're the doctor. If you get paid less, there's no incentive to provide more care to sickle cell disease. You want to limit that because it's bad for business. 40% 30-day readmission rate. You don't get paid when you get readmitted within 30 days. That happens 40% of the time with sickle cell disease. Hospitals do not want to treat these patients due to poor reimbursement. I get transfers all the time, and I never turn anyone away, but the other people, it's like dealing with a hot potato. So the patients end up getting very poor care. This is a study from over 10 years ago. I was just finishing my fellowship at the time, and you can see just these are percentages. About 5% of adult hem-onc fellows go into this area of hematology where you specialize in clots and red cell disorders. So we have a real disparity there, and nobody focuses on it despite the large number of patients. And it gets even worse when you look at research funding. These are research publications over the history of the biomedical literature for sickle cell disease in red, hemophilia in blue, and cystic fibrosis. So they're comparable genetic diseases with a very poor outcome. But you can see that there are more research publications in CF and hemophilia, and correspondingly, there are more FDA-approved drugs. So if you don't do the research and development, you don't get new breakthroughs and new therapies. And it's often said that there are so few physicians in sickle cell, the NIH has a hard time identifying people to review grants because there are so few of us. And then when they do give somebody a grant, that buys 20 to 75% of my time away from patient care, and there's a measurable impact on care for patients. So let's talk about World Sickle Cell Day. This is actually the 6th observance here at Howard University, but the 10th anniversary for World Sickle Cell Awareness Day. So where did this come from? The UN General Assembly, 63rd session, agenda item 155, passed 22nd of December 2008. It recognized that sickle cell anemia is one of the most lethal genetic diseases, and that we are aware of the need for greater international cooperation, taken right from the text of the resolution. Urges member states to raise awareness of sickle cell anemia on 19 June every year at the national and international levels. So how did this come to the attention of the United Nations? This came out of the first global consultation on sickle cell anemia, and this was held in Brazzaville, Republic of Congo on 14 June to 17, 2005. And this is a media release about the meeting in the French literature. And from this came a UN report, Sickle Cell Disease in the African Region, Current Situation and the Way Forward, published in 2006. And this really brought things to the attention of the General Assembly of the United Nations. But how did this meeting really happen? Well, there's a method here. At the meeting in Brazzaville, it was attended by 5 first ladies of African nations that are all affected by sickle cell disease. Not the most affected, but the ones where they really think about this. And those were Chad, Senegal, Mali, the Central African Republic, and the Republic of Congo, Brazzaville, where the meeting was held. I have to say, for the First Lady of the Republic of Congo, Brazzaville, she really attends these scientific meetings. She sits in the front. She stays awake, better than most of the doctors who are in attendance, and really pays attention. She's a lay member of the audience, but she really pays attention and asks really good questions. So after that meeting in 2005, the Republic of Congo put forth $1.4 million for a center in their capital city to focus on sickle cell disease. In the center, in the pink dress, is the First Lady of the Republic of Congo. This is at the presidential compound last summer in Brazzaville, Congo. We have a relationship with the Republic of Congo and their national center. She is a staunch advocate for sickle cell disease research. And again, she was one of the driving forces. She comes frequently with her husband, the President of the Republic of Congo, to the United Nations meetings up in New York. And sickle cell is always at the front of her attention. So this is the Republic of Congo. It's the northern portion above the north of the Congo River. Brazzaville is the capital. There are only 2 main cities, Pointe Noire and Brazzaville, and it's 80% urban. It rains so much there you can't live on most of the land. It's all jungle. Population is 5 million, but 20% of people at least have sickle cell traits. And that means that they have 75,000 patients in the country. So let that sink in. They're a country of 5 million people. We're a country of 350 million people. We have 100,000 patients. They have 75,000. That's how much of an impact that has on the disease. So it's said that it's a public health problem with economic, social, and health effects in the Republic of Congo. The First Lady has told me most common reason for divorce in the Republic of Congo is having a child with sickle cell. The husband blames the wife blames the husband, they get divorced. It affects enough people that it has a measurable effect on their gross domestic product. That's a measure of economic activity because their workforce can't work. This is what we used to hear about HIV in the early days when a whole generation was wiped out in some African countries. So in terms of their national center, this was opened in 2017, so it was a long delay, but as things go in Africa, it takes a long time to do these things. And $1.4 million is a huge amount of money and a huge investment for a medium-income country. This is our delegation at the National Center. That's a picture of the front of the National Center, and I was surprised this is about 10,000 miles from Washington, D.C. Out in front of the National Center, they have pictures of Howard University Hospital on a poster board. I was floored that Howard University even comes up on the radar in French-speaking Africa. And this is a street scene from the Republic of Congo. As you can see, this is not what we'd expect to see in Washington, D.C. Poorer conditions, not unpaved roads. They've already seen 8,000 patients in the first 6 months that they were open, and they have 3 physicians. Pretty amazing. So again, just to summarize, there are disparities in clinical care and in research funding. There are no treatments available to 20,000 Americans with this terrible disease. That's a lot. There's poor implementation of treatment. We have hydroxyurea, penicillin, bone marrow transplants, 2 FDA-approved drugs, but most of the patients don't get them. There's no consolidated effort for a cure, and as I say, even if we had the cure today, the magic bullet, we don't have enough physicians to really implement it with enough knowledge and skill to be able to provide care. So with that, we've got just click on it.
If you want to say that, that's the first lady receiving an award from the WHO.
WHO,
Just
okay,
now.
okay. So this is just a picture of the First Lady of the Republic of Congo. This year, she received an award from the World Health Organization for her involvement and advocacy for sickle cell disease. This didn't start in 2017 or 2016. She's been doing this since about 2000. It's pretty amazing. She's traveled all over the world and will talk to anyone and everyone who's interested in sickle cell. So with that, I'd like to introduce our Master of Ceremonies. Edward Ivy is from the Health Research and Services Administration, HRSA, with the Department of Health and Human Services, and he'll be leading us in our program today.
I don't know if we want to show the video.
Do we have?
No, we don't have
No,
enough
okay.
time. But
We'll skip it. Okay, Dr. Ivy, thank you.
So I'd like to thank Howard University for inviting me here today to serve as the Master of Ceremony. I guess I'll start first with a proclamation from the Mayor, Muriel Bowser. Whereas this year is the 10th anniversary of the Declaration of World Sickle Cell Day by the United Nations General Assembly, and whereas sickle cell disease is a group of blood disorders typically inherited from a person's parents, and the most common type is known as sickle cell anemia. And whereas sickle cell disease typically begins around 5 to 6 months of age, and a number of health problems may develop, such as pain, anemia, swelling in the hands and feet, bacterial infections, and stroke. And whereas in 2015, it was reported that about 4.4 million people have sickle cell disease, and 43 million have sickle cell trait. And whereas today, the Howard University Center for Sickle Cell Disease is hosting its 6th annual World Sickle Cell Day Symposium reception to inform medical professionals, patients, families, and community-based organizations about the Cure Sickle Cell Now initiative, Patient Engagement Symposium. Now, therefore, I, the Mayor of Washington, D.C., do hereby proclaim June 19th, 2019 in Washington, D.C. as World Sickle Cell Day. And this is the proclamation. So I'm just going to give a quick background about my personal experience with sickle cell disease. And as I said, I am very honored by Howard University for letting me be a part of your program here today. As it was pointed out, Roland Scott was very instrumental in making sure that sickle cell became a national priority. So as an individual that's 48 years old and living with sickle cell disease hemoglobin SS, I can tell you that I had lots of personal experience with sickle cell disease. Now, you've heard that sickle cell causes a lot of pain, and growing up as a young child, I can tell you that there were a lot of pain crises and events. However, pain was only part of the story. Can you imagine missing a week or a month out of school and what that does in terms of your social life and trying to, get your education? So sickle cell definitely had the pain part, but it had other parts that we sometimes ignore when we talk about the health aspects of it. But I figured out methods and strategies for living with sickle cell disease. I determined what were those things that made me sick and how do I stay healthy and well. And in the process, I said, well, let me plan out my life. And one of the things I wanted to do was go into the Air Force and be an Air Force pilot. So when I got to high school, I joined ROTC. I said, okay, I'm going to go ahead and make sure that sickle cell doesn't dictate my life. I'm going to take charge, and I'm going to find a way to get into the Air Force. But my mother, she would always say, well, Donnell, you can't go into the Air Force because you have sickle cell. But I wasn't listening to her. I was going to find a way to get into the Air Force. So I got into ROTC. I took the ASVAB, which is the Air Force entrance exam. You know, a lot of recruiters were calling me. I was getting ready. I'm about to go into the Air Force. And then a recruiter called, and he said, can I come over and visit? And I said, sure, I would love to talk to him. He sat down, and he started talking to me about my career in the Air Force. I sat and I listened to him. And then my mother said, well, Donnell, you can't go into the Air Force. You have sickle cell. The recruiter stopped in his tracks. He looked at me and looked at my mother, and he said, what type of sickle cell do you have? Now, I knew I had SS, but I kind of played it off and said, I don't know. So at that, he said, well, we have to go ahead and get you tested. And I knew that the end result would be I wouldn't be able to go into the Air Force. Now, at that point, I was really devastated. Sickle cell had really taken control of my life because it dictated now that I would never be able to achieve my lifelong goal of joining the Air Force and being an Air Force pilot. And as my favorite poet and author, Langston Hughes, says, you know, what happens to a dream deferred? I felt like I could explode. I was very, very upset. But fortunately, in my planning process to go into the Air Force, I had done well enough that I was prepared to apply for college. So then I was the first in my family to go to college. I attended North Carolina State University, and sickle cell there remained a challenge because I would have frequent crises, 4 or 5 crises a year that would require hospitalization. You know, imagine taking biochemistry and genetics and physics, and you have to miss a month out because you're sick and you're in the hospital. And friends would often say, well, why don't you just, stop, withdraw from the semester? But I was like, well, I'm going to continue to get sick. So if I withdraw from the semester, I'll just have to, I would stay in a vicious cycle and never get through my degree. So I decided to kind of tough it out. My GPA kind of suffered some. I didn't do well. And this continued until about my junior year in college, my third year. And at that time, I had a severe crisis. I was having pain in my legs initially, and then I went to the hospital, and my situation got worse and worse. And then eventually they had to intubate me, which means they had to put a tube down my throat and have the respirator breathe for me. And I had what was called acute chest syndrome. I wasn't aware of that at the time, but I almost died. So I come from a very poor family. And my mother, so we didn't have a car. My mother, she had schizophrenia, so she, did the best she could to raise us, but we had limited resources. So for her to get from where our home was in Goldsboro to Raleigh, North Carolina, where I was going to college, was a real struggle for her. So I figured there must be something up for her to be here. My situation was so critical that they had to transfer me from a hospital in Raleigh, North Carolina to Chapel Hill. And there I met the doctor that initially talked to me about hydroxyurea. Now, first I was a little skeptical about hydroxyurea. It's a research drug. I don't know if I want to be a guinea pig. You think about what happened to the Tuskegee experiment. But then the doctor said to me one day, he came in and he said, well, Donnell, there is a chance that you can take hydroxyurea and you could probably develop cancer 10, 20 years from now. We don't know. But there's also a chance that you can have another episode of acute chest syndrome next year or within 6 months, and you can die from that. Sickle cell is a severe disease. It kills people. So it was very important that I start a medication that would really help me control my disease. And I have to admit, hydroxyurea was a life changer for me. I went from having 4 or 5 crises a year to not having crises in 9 and 10 years. Thank you. Since I've started taking hydroxyurea in 1995, I've had 3 crises. So over the last 20 years, I've only had 3 crises. And some of those I question, well, were they crises? Because I went to the hospital and I wasn't admitted. It was abdominal pain or it was a little pain that, could have been from something else. So hydroxyurea allowed me to stay healthy enough to go to medical school. And I went through medical school. I got into my residency in pediatrics, and it was during my pediatric residency that I observed that although we had hydroxyurea, people didn't have access to it. We weren't getting the medication to the people that need it to stay healthy. So I decided that at that point, my future wasn't in practicing medicine, it was going into public health. How do we make sure that people that need the medication have access to it? So I went back and I got my master's in public health, and I started working first at NIH, and there we worked on sickle cell guidelines to try to help providers understand how to treat sickle cell disease, what are some of the treatments that are available. And now I'm working at HRSA because, as it was mentioned, we don't have access to the care. We have hydroxyurea. There are other drugs, and you'll hear from Pfizer in a few minutes, Rivipanzil that's coming. There are some very good drugs that are coming to treat sickle cell disease. But we're also going to have to ensure that the people that need the medication can get it. So I'm going to not take any more of your time. Right now, I'd like to introduce our next speaker. Our next speaker is Dr. Freda Lewis Hall. Now, Dr. Lewis Hall is the Chief Patient Officer and Executive Vice President at Pfizer. Dr. Hall has a long career in medicine and is one of the frontline healthcare providers as a clinician, a researcher, and a leader in biopharmaceuticals and the life sciences industry. Dr. Hall graduated from Johns Hopkins University and earned her medical doctorate at Howard University College of Medicine. Dr. Lewis Hall has served as the vice chairperson and associated professor in the Department of Psychiatry at Howard University College of Medicine and was an advisor to the National... Whoops. Hello? So she was an advisor to the National Institutes of Mental Health. Dr. Lewis Hall regularly appears on health-related television programs in major global markets, including CBS syndicated shows as The Doctors and Dr. Phil. Ladies and gentlemen, please welcome Dr. Lewis Hall.
Thank you for that introduction. I'm glad you didn't do what someone did to me once. In the middle of all that, he looked up and he said, "You've had a hard time holding down a job, haven't you?" So it is, well, thank you for that very generous introduction, and thank you all for being here today. It is always great for me to be home here at Howard University. So I want to do a couple of things today. I want to talk a little bit about the framework of all of the needs for the adequate discovery, development, and treatment access for patients with sickle cell disease here in the United States, but also around the world. It's really interesting because if you do the throwback, okay, I'm gonna let you do some relative magic there. We hope. So here at Howard University, I learned three things: to learn, to listen, and most importantly, to act. And Dr. Scott was really a forming factor for me in my career and in my life. This is someone who dedicated himself quietly, forcefully, and effectively in shape-shifting the space in which we operate to discover, oops. Oh. I'll get closer. Is that better? Okay. So he was quiet, he was forceful, and he was highly effective. And frankly, he shapeshifted what happened for patients with sickle cell disease. And he exposed us through his work to experiences that I think shaped the way that we think about the importance of the disease, the impact on people and their families in the community, and things that we personally can do that change the fate of patients with sickle cell. I'm going to recount two experiences. One was in 1980 when I started my internship in pediatrics here at Howard University. I was so excited. I had a white coat on, I had an MD badge, and I got my first call down to the emergency room. apparently a toddler in crisis. I came down to this floor, the elevator doors opened, and I could actually hear her screams when the doors opened. And there I was expecting my first child. You can question my judgment about being a pregnant intern later. And in I went to work what I thought was my new medical magic. 1980. What was my protocol? Not much of anything. For a child that size, there was little you could do around pain management safely without depressing her respirations. There was little you could do but hydration, and then you were out of things to do. The protocol was short, insufficient. And there was a young mother there who cried like no tomorrow for a day and a half while her baby suffered, and she did nothing. And there I was, this newly minted doctor that thought I was hot stuff, and I had never felt so powerless and so useless in my life. So what I did was relieve her every few hours when her rocking and crying wore her out, and I took over, and I rocked and cried for her with her baby. But when that experience was over, I thought to myself, what is wrong with us as a medical community that could allow this kind of suffering with so little effort to change the course of it? Now, the real shame of it is what Dr. Taylor shared with us. And that is, right now today, if I went to the same emergency room and had a baby in crisis and a mother suffering with her, I would have little more to offer than I had to offer in 1980. Now, that is the bad news part of the story. The good news part of the story is that science is catching up to our need. We have Star Wars science on the horizon for sickle cell. Genetic motion that is going to allow us to cure the disease we expect and hope. New medications that are targeted to prevent or to ease if a crisis occurs. The entire spectrum of opportunity from a scientific, from a biomedical standpoint, is right here in our hands. The other exciting news is that the policies, the platforms, the resources, and the support are finally coming our way. If you look at what's happening now at the NIH, a focus on sickle cell, $100 million worth. If you look at what's happening in the biopharmaceutical industry, hundreds of millions of dollars of investments, experts, intense research to help change the course of sickle cell disease. So think about it for a second. We're poised with the science. We're poised with the resources, at least on the discovery end. So now we have two things to solve for. The first is actually getting those new medicines and therapies developed. And I want to talk a little bit about that. Right now, today, the historical review for the number of treatments that have come into the system but have failed to advance is relatively high. Now, the attrition rate or the fallout rate for new medicines and therapies is very high anyway, because science isn't perfect, and sometimes we try and fail. But about half of the treatments that have not advanced in sickle cell disease have not advanced not for poor science, but instead for the lack of participation in clinical trials. Clinical trials in sickle cell do not enroll enough patients fast enough to advance therapies. And about half of them have died on the vine, if you would, for want of that kind of participation. So I went back and I started looking at the literature on why there is such a woeful lack of participation in clinical trials. And there are so many studies and academic articles and treatises on this space. It was a lot to synthesize, But there were a few things that became clear. The first is we don't do a good job as a scientific community of understanding fully the needs and the barriers for patients with sickle cell disease and their families. So the design and the implementation of clinical trials often does not meet the needs of patients, or they can't actively participate. We also found in these studies that patients had a difficult time believing that they should and could trust a system that has treated them so poorly. So we ended up finding out from patients that there are several kind of reasons, if you would. One is purpose. Why should I participate in a clinical trial? And we, as a biomedical community, I don't think have done a good job of explaining what the potential benefits are, what the potential risks are, and why it would be juice worth the squeeze for patients to kind of run the traps of participating in a clinical trial when their lives are already as complicated as they are. The second is emotional. I had the opportunity to interview T-Boz, for those of you that know her. Well, I see some nodding heads, which means some folks in here have some TLC CDs in their houses. But she told me things that I would never have thought about her. Her experiences with sickle cell have been personally distressing. So this is someone who's been a part of selling 45 million records. Y'all know what those are, right? Digital downloads of music over time with TLC. Yet she said when she goes to the emergency room, they eye her up and down because they think she's looking for opioids. That sometimes when she just has bone-crushing fatigue and is ready to go on stage, that the rumors start to go around that maybe, she's kind of looking for something. And so even someone that has stature in the community, if you would, finds herself the victim of stereotype and stigma when she goes for help into the healthcare system. And when we had our conversation, I asked her, well, what about a clinical trial? And she made a, oh child, please face at me. Why? Why would I do that given this is the way that I'm treated? So we understand the emotional aspects of this and that there is, frankly, reason to be mistrustful of a system that has mistreated you. And then there are the practical issues that I mentioned earlier about our clinical trial design. We have done a woefully bad job of asking patients and their families what they need and taking their needs into consideration. So a lot of the articles that I read used focus groups and they used surveys. And the information that was received was really good. And when I worked at our company to help articulate or put together our protocols for our clinical trials, we talked to patients as well. And then we went out and started to recruit for the clinical trial and found that recruitment to be very slow. So we were thinking, what did we maybe miss? And we realized that sometimes asking is not enough and that observing gives you better information. So I'll tell you a personal story to demonstrate my commitment to listening and observing that has nothing to do with sickle cell disease. So I'm a very finicky eater by background. Like somebody who knows me is laughing because maybe that's saying it lightly. I'm a very finicky eater. So I was at a public dinner. There were about 15 of us. And they brought out a plate of food on a fixed menu. And on the plate was like stuff I wasn't going to eat, like octopus stuff and, a little crayfish with like one eye. And so but I didn't want to complain. So I started to pull the peas that were in the rice out to make a little pile, and I was going to eat the peas. I'm not going to bother anybody. I'm just going to eat this pile of peas. So everybody else is eating their food. I think everybody's fine. So, I'm doing my little thing. And a waiter comes out, stands over me, and says, "Do you eat chicken?" I said, "Yes." And he walked away. That was all he said. And so I looked at him and, continued my little pea piling situation. And a couple minutes later, he comes out of the kitchen and puts a half of a chicken, deep fried, grease still popping, and some fries on the side. I was so happy. So he took the plate of the other stuff away, and then everybody else sitting at the table was like, "How did he know you wanted chicken? How did you get that? Did you order it?" And I didn't know how he knew I wanted something else. So finally, one voice at the table said above all others, "I just want to know how he knew you wanted chicken." And the waiter was at the door, and he looked over his shoulder and said, "Because I knew she didn't get that big eating peas." So sometimes you just have to observe and interpret. So we did a classier act of that, we think, and the results were stunning. So we had an ethnographer work with patients to follow them for 18 hours a day, just live with them and observe. And we found out things that were incredible that we could never have found out by asking. For example, patients are willing to suffer in crisis for hours, if not days, to prevent going to the emergency room for a whole host of reasons. The questions that get asked are why, so observing, why would that be the case? And what we observed was that in some cases, patients didn't have transportation. And they knew that if they called an ambulance, the ambulance took them to the nearest hospital, not necessarily where the people that they knew and trusted would be. So there were many reasons for why this happened, but observing, being a part of it, listening to the conversations gave us insights. The second thing we learned, because we were studying patients who were in crisis, they were like, "Y'all had to follow somebody around for 18 hours to find this out?" But patients were in crisis, and there we would come with a 20-page consent form talking about, "Do you want to sign up for a clinical trial?" They were like, "If you don't get out of here." So, there were some obvious things, but things that I guess when you're sitting at your desk you don't think about. But you did think about if you actually followed someone and were experiencing with them what they were experiencing. So there were opportunities for us to actually change the way we thought about how we conducted our clinical trials. What if you simply provided someone transportation to the place they needed to be when they were in crisis? What if you read through the consent form with them before they were in crisis and had them assent then so that you didn't have to bother them when they were in the throes of a crisis? What if? And we did all of these what ifs. We engaged patients to help us understand if we had thought this through properly, and lo and behold, our larger pivotal trial enrolled faster. Now that's a good news story, I think. But isn't good news enough? Because now there are a host of other things that are about to happen. More trials are going to start with very few centers, as Dr. Taylor has told us. So now, where are the investigators coming from? How will we engage them? How will we be sure that they are ready to handle the volume of patients that need to come into the clinical trials if everyone raised their hand? So we have more to do. All of us have more to do. And so we have an opportunity to address some of this now. So I want to make one other point, and then I'll close and pass the baton. And the point that I really want to, I'm just going to hold this. So the point that I really want to make about this is that we are changing the way we want to do clinical trials. We don't want to design them, figure out where we're going to do them, and then come to you and say, would you participate? Would you do this for us? Can you handle that? We want to start at the beginning, asking the right questions, observing what needs to be observed, asking the experts, patients, and caregivers, are we on the right track? What would you do differently? And then engage to deliver treatments into a system that is better designed with better policies and a more focused effort to make sure that patients who need our help get it. So I want to end with one last story. It's a story of a friend of mine who died 18 months ago at the hands of sickle cell. Now, she was an incredible story because she defied it all. She did what she wanted to do. She went where she wanted to go. I got a call from Brazil, when we need a place to get her admitted to the hospital. I was like, what's she doing in Brazil? So she defied all of it until the end. And one of the most poignant experiences for me was when she faced an amputation. Her mother had prided herself in saving her limbs and her eyes and her kidneys all the years that she took care of her. And the moment that she lost her foot was a defining moment for her full life, and for her mother's life. And I'll never forget that it's every day, all day, every week and month and year that we are obligated to serve patients who are living their lives to the absolute fullest if there's help that we can offer. So I beseech each of you to continue to do what you're doing, and I thank all of you for your commitment to the work that's being done in this area. Thank you.
Thank you very much, Dr. Lewis Hall. That was a very great speech. Our next presenter will be Dr. Keith Hoots. Now, I've worked with Dr. Hoots quite a bit since I've been here in Washington, D.C., particularly when I worked at the National Heart, Lung, and Blood Institute. Dr. Hoots is the director of the National Heart, Lung, and Blood Institute's Division of Blood Diseases and Resources. He received his Atrium Baccalaureus in English and Chemistry and his MD from the University of North Carolina at Chapel Hill. His major interest involves the management and diagnosis of congenital and acquired bleeding disorders and clotting disorders. His work includes the creation of longitudinal follow-up of hemophilia cohorts with HIV and hepatitis, gene therapy trials for hemophilia A and B, clinical trials for new clotting concentrates for hemophilia A and B, and the impact of care and clotting factor products on hemophilia patient outcomes. Now, recently, Dr. Hoots has been working with me and others on improving sickle cell care. So he's very involved in finding strategies to improve care for sickle cell disease, including looking at gene therapies. Dr. Hoots has a strong interest in global collaborations and in developing private and public partnerships, and recently completed his sabbatical in Belgium. Dr. Hoots.
Can we just, so that you don't get any somewhere, I think. Is this one right here? And it's, yeah, let me just, let's see if I can. Yeah, it's supposed to go with how, yeah, I don't know. I can, should be somewhere, just a second, give me just one second. Yeah, this one. I need to quit, yeah, just quit. So that we don't get any calls when we're talking. No, that's a good idea. Like he's calling about the BOA project. So which one is this? This one, right? Yeah. Okay, so this one. Okay, sorry about that. And there's oh, you have a pen.
Thank you very much, Donnell, for that kind and generous introduction. It's a great pleasure to be here in my city as well as yours. It's a joy kind of to come here. I've been here a while, and this is my first visit, and I feel like it's been too long. I should have been here sooner, but it's great to be here and to participate in this really important conference. The two previous speakers are tough individuals to follow. I wish that I could speak with in some ways with the same gravitas that they've provided. Rather than trying to even try, I'm going to try to tell you what we are trying to do at the National Heart, Lung, and Blood Institute of the National Institutes of Health. I will talk about a couple of programs that actually follow on with Dr. Taylor's introductory speech, and also on the second part of my talk with Dr. Lewis Hall's speeches about, or talks about, how important implementation is to do research in the field of hemoglobinopathy, specifically sickle cell. So that's why the first slide is titled the way it is. Now you might ask yourself, well, why is, if we've got all these needs that Dr. Taylor so well articulated here in the United States, would the National Institutes of Health put an emphasis on international? And I think you got a clue of that, about that from Dr. Taylor. It's part of the reason is, and I think if I've learned anything in my decade here at NIH and focusing a lot on sickle cell rather than other areas which were in my academic past, it is that you must go, if you're going to do clinical research effectively, you have to go where the patients are. And you heard that already. And they're here in the United States, but they're around the world, and particularly in sub-Saharan Africa. So suffice it to say that we had no presence as the Division of Blood Diseases in sub-Saharan Africa in 2013. As I'll show you in just a second, we are now in 11 countries. And our whole idea has been that we can learn as much, or maybe more, from research that's developed and implemented in Africa as they can learn from what we are doing here in the United States. And I think we've learned enough in the 6 years since to say that that's the truth. And I'll try to give you some examples. If I can get the slides, or I'll just use this one. I should say before I get started that our next speaker, Dr. Ed Benz, and I decided among ourselves that we were going to focus on two aspects of what we're trying to do at NIH. I'm going to talk about two programs, as I said, that we have implemented, pun intended, over the last 3 or 4 years that are targeted in our traditional budgetary fashion for funding sickle cell. Dr. Benz is going to talk about our new effort in trying to cure sickle cell. And hopefully the two will integrate well and complement each other, and during the questions we can try to do even better job to make sure that happens. So I don't have to go through a lot of the details on my first couple of slides because you've heard the germane issues from Dr. Taylor. Suffice it to say, another way of saying what he told you is that there are more babies born in Nigeria in any given year with sickle cell hemoglobin SS than there are total patients with hemoglobin SS in the United States. That's how big an issue, and that's just one country. A big country, but nonetheless, just one country. And more importantly even than that is that, at least according to the World Health Organization, half of those babies will not make it to their 5th birthday. That's profound. And we felt like that was something that we as health professionals, in the same way that Dr. Lewis Hall has told you, we could not ignore that. That had to be part of our armamentarium. And we started out conservatively in terms of dollar resources, but we felt like we had to prove a principle. Second principle we had to prove was that we could do this by supporting the people who were there, the professionals who were already there. That we couldn't do this as coming in helicopter fashion and saying, we are going to tell you how to treat sickle cell and do it effectively. Now, we do some of that because we have people who were already there on the ground who are from Europe and the United States. But primarily, our focus has been on funding directly the hematologists and the other care physicians there to build an infrastructure and who've already demonstrated that they can do high-powered research even with low power resources. So that said, these are the places where we are. All the places across equatorial Africa shown by the stars, all 10 countries, are places where we are in clinical research. The one star at the bottom is in Cape Town, South Africa, because what we realized from our own research experience was that you can't build an infrastructure for effective research if you don't have the right data systems in place to collect the data, analyze the data, and publish the data. Things we know well because that's what we do every day here at NIH. So I'm going to tell you about 3 programs very briefly. The one that we actually implemented directly and is still kind of our proof in principle is called SPARCO. And it's, as you can see up there, it's a Pan-Africa consortium. The principal investigator that was competitively chosen from applications across sub-Saharan is Dr. Julie Makani in Dar es Salaam, Tanzania. And she put together a consortium of 3 major countries, Tanzania, Nigeria, and Ghana, to prove in principle and to develop infrastructure and show that over the course of a 4-year grant, they could do it, that they could collaborate with a data consortium that would help them build the pyramid that would allow this to happen in Cape Town, and that they could do it effectively and make the case and put the pressure back on us to say, well, you did what you asked us to do, we did what you asked us to do, now support us farther down the line. And that's kind of where we are. I'll show you some data to support that. The most important thing is that they were targeting 13,000 patients in these 3 countries. By any standard, even cardiovascular disease in the United States, which I know a lot about because that's what Heart, Lung, and Blood does in a big chunk, that's a pretty big number. And I'll show you that they're right on line to do exactly that, enrolling them in a registry and building the infrastructure to recruit them for trials that they will design. Now, there's another program which actually originated here in the U.S. that we now are funding, which originated from the University of Cincinnati. The principal investigator at University of Cincinnati is Russell Ware. But he had already built a bridge over to Uganda in particular, but also Kenya and Democratic Republic of Congo. And their purpose was, with their initial plan, was to find out if you could introduce hydroxyurea in infants and young children in Africa in a safe way, and then demonstrate whether, if it is safe, is it effective there, and can you bring the dose up to a level that really works. So they were about 1.5 years into that project when they applied for us to support them, because it's obviously doing clinical trials is expensive. And they got a very high competitive funding, or very good competitive funding score, which means a low score for us. And we funded them in what has become a cooperative agreement. And over the 3 years since we started with them, and over the 2 years that they had already been on the ground in those 3 countries, they have recruited 500 children into hydroxyurea. And the one number I want you to remember is from this study is that their recruitment and retention has been phenomenal. They've recruited almost 90% of the people that they've approached, and they've retained over 90 to 95% of them in the study for 5 years, which is now going to extend to 8 years. And that's numbers we would die to get here, as you've already heard. So I'm just going to say, to show you just how impactful that people in the scientific community have found this to be, the lead Ugandan investigator, Dr. Shehilo, presented their in-progress data to the American Society of Hematology this past December, and then the following week, the data that he presented on behalf of all the authors that you see up here from both from all three countries plus from University of Cincinnati was published in the New England Journal of Medicine, which many of you will know is probably the most prestigious place for any clinical trial to ever be published in the world, along with Lancet perhaps. And they were able to show that they could do phenomenal things, not only recruit and retain, but they could do, with the help of laboratories back in the state, here in the States in Cincinnati, they could analyze pharmacologic data on what the levels were in these children to make sure that they were at the targeted level, because what they were not satisfied with was they didn't want to just take the lowest dose that somebody had shown might be effective, because then they might miss a lot of kids with the efficacy. So the range runs from about 15 milligrams per kilogram up to 35 milligrams per kilogram max dose in children. So they've been able to take the dose in some children all the way up and follow for toxicity, which is looking at their total blood counts. And they've been phenomenally successful, and they've reduced morbidities and raised hemoglobins remarkably. I will refer you to the article, which you can see right. I didn't put the date on. I think it's December 19th, 2018. So, but there's a lot of data. It's really a lot of important data. But in the interest of time, I wanted to give you some more studies as well. One that I'm going to mention briefly is one that was actually started in a collaboration with it's called H3 Africa. It was created by the Wellcome Trust in the United Kingdom and the NIH together about 5 years ago. And then about 2 years ago, they made a decision to include sickle cell in their broad diseases. All the other diseases, as you'll see from one of my slides, have been focused on common diseases in large populations, like heart disease, chronic obstructive pulmonary disease, asthma, that sort of stuff. But they made a conscious decision to include sickle cell a couple years ago. And because we're the team at NIH that does sickle cell, they came to us and asked us to manage this part of their portfolio, which we're really happy on. And it's concentrated on a totally different thing, which may have actually huge impact on what Dr. Benz is going to talk about in terms of our cure strategy, because they're going to be looking at gene and clinical response correlations in West Africa and East Africa both. And there may be clues in that will help us decide if someone doesn't respond to our strategies, what might be influencing it, because they're going to be looking at every gene, not just the sickle cell gene. So I'll kind of quickly go through, because I don't want to eat into anybody's time, but this is the vision of H3, which stands for Human Heredity and Health in Africa. And it's to facilitate an African-based research approach to the study of the gene and environmental determinants of common diseases. And in this case, it is common because it's in Africa. And these are their goals, which are pretty consistent with our goals in the SPARCO, which I'm coming to at the last part. And this just shows you who the PI is, who's Dr. Solomon Ofori Akwa from Ghana and from the University of Pittsburgh together. He has a joint appointment. And this is just launching in the last 15 months. So, and this just shows some of the infrastructure that's been built for all the common diseases that can be utilized, but they are building specifically sickle cell laboratories in Accra, Ghana, for this particular endeavor in sickle cell. Now, I'm going to come back now to SPARCO. I want to just show you some of the data from this. I told you what we had tried to do, and this is what they have. Their goals were to develop a database, to develop a registry, and to start laying the groundwork for clinical trials into the future. And I already mentioned that there are two components, the Data Coordinating Center, which is in Cape Town, and the 3 countries. Their aims, I've alluded to. Also, they want to do a regionally appropriate clinical management guidelines. They've done it in the first 2 of a 4-year grant. They want to have skills development. I'll show you pictures from that in just a moment. And to begin planning for cohort studies and newborn screening, which they are doing as we speak. And they still have 2 years left on the grant. So they put the monkey on our back, and we've pretty much had to sell our scientific board of experts, our advisory board, that this is important, and they bought in. So I can't say any more because I would be breaking the law. But I can tell you that we're in here for the near term and the longer term. This is some of the, and you can see that as I told you before, they targeted 13,000 subjects, research subjects, patients, depending on how they were recruited, but they'll eventually be they'll be both eventually. Ghana 3,000, Nigeria 6,000, and Tanzania 4,000. And as of this past April, they'd already recruited almost 6,600. So they're halfway through their funding, and they're over halfway, they're halfway, just slightly past their halfway goal. They've done these skills development in all these 4 areas: management, newborn screening, research, and data management. And these are some of the actual on-the-ground skills development, and I have to say that they've done things that have been pioneered in other diseases in Africa that are with great effect, including using health extenders, people that they train who come from high school or maybe early college, and they just train them to do what they need to have done. And they go out into the cities, and they're starting to go out into the burbs and ex-burbs and into the rural areas in a phenomenal sort of way. So these, I've pretty much told you these already. And the other thing they've done, which is kind of also our envy, is that we've been trying to build a common, what's known as a common vocabulary or ontology for sickle cell in this country. And we have so many different players that it's hard to get everybody on the same page. They've done it. Out of 3 countries, they've done a whole one that uses the same system that we're using here in the U.S. out of Vanderbilt called REDCap. So they have their own data system, their own vocabulary, their own data analysis system in 2.5 years. It's just absolutely mind-boggling. And I've summarized that. So where do we go from here? I can't tell you what we're going to do, but this is what their plans are. They're going to try to link up, and they are in the process of linking up with the other components of what's going on in Africa, including others that I didn't discuss that are funded by other entities, to make sure that they don't duplicate services, that they maximize and leverage the resources that are being provided from anywhere in the world. And they're now focusing on how can they, in the next iteration, implement a newborn screening with the help of their own health ministries. So they have been involved with trying to, not only they've been in liaison since before we funded them, but they are now taking the data that I showed you and telling their health ministry, we can do this. This is what the impact will be if we do it. Let's move forward. So these are the I don't have time to name all the people, but these are the people who bear a lot of credit for this particular program. And finally, of all the 3 programs I discussed, these are the numbers that have been recruited so far. Now, I'm going to end up. Okay, I'm going to end up talking now in completely domestic terms on something that we started. It'll be 3 years in August, and it was and Dr. Ivy alluded to it, and so did Dr. Lewis Hall, about how necessary it is that we understand how to take the new drugs that you're developing and get it to the end user. We don't do that very well in any disease. It takes 17 years for the average disease. And sickle cell, you've already heard how much of even bigger challenge it is, partly because of the system, the healthcare system, which particularly seems to penalize adults in ways you've heard discussed. So we decided that we needed to investigate, are there models that might do this better? And in the new parlance of clinical investigative research, that's called implementation science. And there are actually people, and we required their participation for each of our sites, that are called implementation scientists. Most of them are PhD implementation science specialists. They know how to design outreach studies that will test whether that strategy is good or not good. Just what, kind of like what you did, you know, by sending your people around with patients in crisis. So we've funded that. The other thing we've decided was that we couldn't wait around for a registry to be developed here in the United States. We were doing it in Africa. So we knew that there were efforts already ongoing. We just decided that we had to use this format to make sure that we could ground a registry that would then talk to other registries. And that's part of what we're trying to do in Cure Sickle Cell, which I won't go into. But so we awarded 8 sites for a 6-year grant to first put together a registry to do a needs assessment, which I'll show you some results of both the care providers and the patients in their reach. And they had to come in with a pre-designed regional reach. It could be a big city reach, like one of our sites in Manhattan, and their players in Bronx and Brooklyn, or it could be a whole state, like in South Carolina, and so we've tried to capture rural, urban, and suburban among our 8 sites, and I think we've pretty well effectively done that. And these are the places on the right that we did fund, and you can see that it's bi-coastal, it's Midwest, and East Coast as well. And so we have developed a registry. I'm not sure if we've been as efficient as our friends in Africa, but almost. For this, but this is only this is only in this 2,400 subject sites. And we've conducted a needs assessment, which I'll talk to you about. So the where we are right now, 2.5 years into it, we've completed a needs assessment, or the investigators have. We've enrolled in all 2,400 plus in a registry, and we've started developing implementation science protocols. And I'll tell you what that is in just a second. In the next phase, we take those protocols and we do the testing. Does this strategy work or not, to try to improve people's participation in care and then ultimately in research as well. So these are the topics that people were asked about, and so were the care providers, on hydroxyurea, pain, quality of care, and emergency department care. We use, and again, when I say we, really our investigators, were surveys, key informant interviews, and focus groups. And so then the 3 implementation work groups came up with what they want to study in the next phase, the implementation strategies. Care design, redesign, improve emergency department care, and reduce unaffiliated patients. And I'll walk you briefly through each one. But first, the surveys. So the investigators queried 500 of the original recruits in the among the first 2,400, as well as their providers, as much as they could be identified. They conducted 78 patient focus groups and 102 provider focus groups, and 52 individual interviews among patients and 36 among providers. Among the registries, they managed to pull this off in 18 months, which is what we were demanding. And by the way, this is a grant, but it's what we call a cooperative agreement, which means that it was designed in such a way that we at NIH have a real, so that's why I kind of feel comfortable saying we, because we're integrated. We don't do the work at the sites, but we spend a lot of time making sure that what was in the original request gets accomplished, and troubleshooting if we identify site problems and that sort of thing. So these are the things that have been done. The design is ongoing for the implementation phase, and we're pretty much there, or pretty close, for the first 2. We're not quite there on the unaffiliated patients. But if you think about it, that's probably not surprising, because we're asking them to go out and identify patients that they don't know exist, except by the prevalence of the disease. Or else they might have heard about them, but they never came back. So they had to come up with a definition of what it means to be an unaffiliated, and I'll show you that in a second. And so that'll probably not, that effort probably won't start until the end of this year. The others will start in the fall. So these were by the way, we decided because of the issues that you've heard discussed from Dr. Taylor and Dr. Lewis Hall about adult care in this country, we decided to, and the need and the problems that come with transitioning from adolescent care to adult care, to focus on 15 to 45-year-olds. So that's what these 2,400 individual plus are in this study. And we excluded people who had already undergone a successful transplant because we wanted people who were actively experiencing sickle cell disease. And this is what the registry looks like most recently. It's not completely up to date, but it's pretty close. A few more higher prevalence of females, probably just recruitment challenges. But you can see the age distribution is about what we had hoped, because it's a wider age group in the last category, 26 to 45. So the first one they're going to do is care redesign, and they're using as their endpoint the issue that Dr. Ivy talked to you about, and that Dr. Taylor talked to you about, how efficacious hydroxyurea can be if you can take it, or if you do take it, and how it doesn't do anything if you don't take it, and how in this city only 20% of people are actually taking it if they're adults. So we have to get better. Even if we've got new strategies coming down the pike, the same impediments apply. So this is going to be looking at how to do that, use technology. We will be providing technology for interaction between the patient, their provider, and the researchers to say, okay, we're going to be reminding you, now we're going to check and see if you actually complied, blah, blah, or adhere to the regimen, blah, blah, blah. So that's the first one. The second one is improving emergency department care. You've heard about that already. People coming in, being accused of being drug seeking. So this is a really big problem in this country, particularly right now because of the opioid epidemic. So they're focusing on how to work with ED doctors on site in remote as well as proximal places. That is in their own tertiary center, like here at Howard, or say out in southwestern Virginia, where there may just be a local ER doc or a team of very small just ER practitioners. How can they implement a strategy and test it to see if it works? And finally, I already mentioned about unaffiliated patients and how big a challenge this one is. And so what they're really working on is they've defined it, and this is, I'm not going to go through the definition, but that's up there under unaffiliated definitions. So anyone who meets any of those criteria will be eligible for recruitment. So the real challenge, can they identify them, can they bring them to care, and can they show that that care is continuous? So that's a big challenge, but that's what that third group. And we didn't divide them. We expect every site to do at least 2 of these 3 protocols, and some of them will do all 3. So we're expecting to have enough participation across the 2,400 that we can actually do the statistical powering to answer some of these questions. So I'm going to conclude there and turn the podium back over to our moderator, Dr. Ivy, and thank you very much for your attention.
Thank you, Dr. Hoots. Now is a wonderful time to be in sickle cell. There's been a lot of developments that have been made, and as Dr. Lewis Hall said, we are on the cusp of Star Wars level interactions in sickle cell disease. There are new drugs coming down the pike. There's new science coming down the pike that really will help individuals with sickle cell disease live an improved life. Now, as I've mentioned, I'm 48 years old and I have sickle cell disease, hemoglobin SS, and I know what the pain is like. So to hear these advancements being made is wonderful. But we can't stop with just finding a cure. We have to make sure that individuals have access to that cure. But now you're about to hear one of those Star Wars level interactions or science findings that's on the cusp of being developed. So next we have Dr. Edward Benz, an MD, who will be talking to us, as Dr. Hoots mentioned, about curative therapies. Dr. Benz is the president and CEO emeritus at Dana-Farber Cancer Institute. Dr. Benz is internationally recognized hematologist who is an active National Institutes of Health funded investigator. He began his faculty career at Yale University in 1979. That's a long time. I was born in 71, so. Rising to the ranks of Professor of Medicine and Human Genetics in 1987. He is an expert in inherited anemias. Dr. Benz received his training at Brigham's and Women's Hospital, the National Institutes of Health, Boston Children's Hospital, Yale, and Princeton. So he's been to quite a few well-recognized universities. He also received training at Harvard Medical School, where he received the Soma Wise and Leon Resnick Awards for student research. Dr. Benz is board certified in internal medicine and hematology. Dr. Benz.
I actually don't need my slides for the beginning of my talk, so while Dr. Taylor wrestles with my thumb drive, I'm going to get underway. First, I want to thank you for the opportunity to come and speak here. Those two awards that he mentioned, Dr. Ivy mentioned in medical school, were actually for work I did as a medical student on the molecular genetics of hemoglobinopathies. So I'm 73 years old, not 48. I give a lot to be 48 again. When I was 18, I wasn't doing anything to be 48. So when you get to be 73, what I commonly say about you is that you've been around the block a few times. I happen, in my career, to have been around a couple of blocks a few times. Starting out in my Starting out in, is that okay? You can hear me now? Sorry. Starting out in medical school, as I just mentioned, I started working on hemoglobinopathies, thalassemia syndromes, and sickle cell anemia, and on through pretty much the first 20 plus years of my career was still publishing in that area. Then through a variety of the kinds of things that happen in a career, I ended up being asked to be president of the Dana-Farber Cancer Institute. So I spent 16 years running one of the larger cancer centers in the world, and still a member of the faculty at Dana-Farber. And it's caused me to reflect on some of the parallels and differences between what we're talking about today dealing with sickle cell anemia and what's happened in the world of cancer. So when I was a medical student, the cure rate for childhood leukemia was 0. You could get remissions, you get people to live a few years when once they'd only lived a few weeks, but the cure rate was 0. Now the cure rate for patients with the major form of acute lymphoblastic leukemia in children is upwards of 80%, and probably going to get to 90% pretty soon. When I started at Dana-Farber in the year 2000, there was a disease called chronic myelogenous leukemia, where patients rarely live beyond 2 or 3 years unless they got a bone marrow transplant. A new drug had been developed called Gleevec. This happened to be the year I was president of the American Society of Hematology. In 2000, the results of the major clinical trial were presented, and now the chance of living decades, and many patients probably cured, with either that drug or a combination of it and some ones that have followed, is well over 80%. So in sickle cell disease, as you've undoubtedly heard today, it is possible now to live longer and longer, but we do not have a definitive cure. I'm going to talk in a minute about what's on the horizon there, and why the reason why I mention these examples in the cancer world is what was it that made it possible
Was it the science? Sure. There was great science developed, but there's been great science, as we've everyone here has pointed out, that's been done on understanding sickle cell anemia, and even some excellent science has been done on developing approaches to therapy. The difference is that a child with childhood leukemia who goes to a physician now is about a 50 to 70% likelihood of being enrolled in a clinical trial. So it was because you could take what was being learned and learn how to put it into practice and make it widely available that those cure rates changed. As soon as the drug Gleevec was announced, patients oversubscribed every clinical trial. And so I mentioned that other block that I've been circling because I think in sickle cell, we are on the cusp of solving one of the major problems, which is how do you cure the disease? It's not there yet, but as I'm going to mention, it's almost there. But the second problem, and I think the more major problem, is how do we make sure that everyone can get that therapy, and that everyone not only can get that therapy, but does get that therapy. There are some huge technical barriers right now, but we will never get past the technical barriers if we don't create a climate, an environment in which patients are enthusiastic about joining the trials and in which we make it feasible and as easy as possible and as safe as possible for them to join the trial. So that's why I'm so grateful to have a chance to talk to all of you, because I don't often get to be in rooms where everyone in the room understands fully the urgency and the importance of achieving not only the first goal, but also the second. Now, I'm going to spend just a minute or two at the risk of telling you what you may have already heard this morning. I'm sorry I couldn't be here for this morning's presentations, but I decided it'd be better to err on the side of having you hear something twice than not at all. So if I've repeated perhaps more poorly remarks that other people made this morning, I'll apologize in advance. So I want to just talk a bit about the disease. And this was 75th anniversary of D-Day, and there was quite a bit of hoopla about this. There should be. An incredibly important event in human history. It's also this year the 70th anniversary of the recognition that sickle cell was a molecular disease. Not only was it a molecular disease, but we knew what the molecule was. It's hemoglobin. And it was within a couple of years after that, we not only knew that it was hemoglobin, we knew which part of hemoglobin it was. It was the beta globin chain component of hemoglobin, which is present only in adult hemoglobin. The beta chain is in hemoglobin A, which is 95% of the adult hemoglobin that circulates in our cells from the time we're about 8 or 9 months of age on through the rest of our life. We've also known for decades that infants with sickle cell disease are born destined to have the disease, but they're not born with the symptoms of the disease. And we also know why that is true. And again, at the risk of your already knowing this, it's because we're born and throughout our prenatal life and the first few months of life, we live off another hemoglobin called fetal hemoglobin, which has a gamma chain instead of a beta chain. Now, the reason to highlight that in talking about definitive cures is that we have known for decades from examples of patients who are born with no adult hemoglobin whatsoever. They have a condition called hereditary persistence of fetal hemoglobin. You don't need to remember that. Just remember that these patients can't make adult hemoglobin. Yeah, that's why hematologists make the big bucks. We have all these terms. But these patients don't even have the gene for adult globin, for beta globin, but they are able to make fetal hemoglobin at a very high rate, just like the normal rate that's made during fetal life, and they live perfectly normal lives. So we've always known that there was a therapeutic strategy out there, prevent that switch or do something to revert back to fetal hemoglobin production. And what's even better about that is we've known for decades that hemoglobin F would not only be a good substitute for for adult globin and replacing the sickle globin, it also actively inhibits sickling. So if you have a mixture of hemoglobin F and hemoglobin S, it's less likely to sickle than a mixture that's only hemoglobin S, or even a mixture that's hemoglobin S and A. So, that fetal hemoglobin is a potentially wonderful therapeutic agent for us in that it can replace sickle cell, reduce the amount of sickle hemoglobin that's in the cell, but it can also inhibit sickling by any of the sickle cell hemoglobin that happens to be in the cell if you at best can make a mixture. So that leads me to the definitive therapies that are on the horizon. One is to do something that causes patients with sickle cell anemia to make much more fetal hemoglobin. Maybe it's right now not possible to get a complete switch to make the cells look like the ones you're born with in fetal life, but to make enough fetal hemoglobin that between the replacement of the sickle and the inhibitory ability to stop the sickling, that by that combination, and we know something about what that is. It's on the order of 20 or 30%. It will give you a significant change in the tendency of red cells to sickle. So that's one strategy. The second strategy, which would be in many ways the ideal one, the one we thought about decades ago when we began to know what was going on in this disease, would be simply to use some genetic technique to eliminate the sickle hemoglobin and replace it with normal hemoglobin A. That is a holy grail that's turning out to be a little bit more difficult to achieve, but it's doable I hope in my lifetime, but certainly in those of many of you in this room. And then the third strategy is if you can't completely substitute or replace sickle hemoglobin with normal adult hemoglobin, why not engineer a hemoglobin that, like fetal hemoglobin, is an anti-sickling hemoglobin? And we've known from people who there are hundreds and hundreds of mutant hemoglobins out there in the world. There's one at almost every amino acid of the hemoglobin molecule. Many of them have no real physiologic consequences, but some of them can make the tendency of sickle hemoglobin worse, and some can make it better. So we know a few of those, and in fact there are now therapeutic trials in which you actually, the gene that you transfer in is for the hemoglobin that is not regular hemoglobin A, but is instead a hemoglobin that's engineered to block sickling. So you not only get, again, like with fetal, you not only get the replacement value, but you also get the inhibition of sickling. So those are the three kind of strategies that people have begun looking for ways to pursue. And that is where we come in the Cure Sickle Cell Initiative. And I'll tell you a bit about how that works in just a second. So how do you do that? How do you actually fix the hemoglobin in one way or another? Or at least get enough of a fix so that you get rid of the sickling problem. Right now, there's only two methods to do that. One has been used to cure patients with sickle cell anemia, a number of them. There may be patients in, has anyone here had a bone marrow transplant for sickle cell anemia? Yeah. Yeah. Yes. So as you know, if you make it through the bone marrow transplant successfully, you can end up with a major clinical improvement and theoretically at least a cure. Of course, the problem is the mortality of bone marrow transplant under the best of circumstances is 10 to 20%. You have to find matched donors, which is not so easy, and you have to have access to a place that has the infrastructure to do sickle cell. Yes? Yeah. It's not so much female to female, male to male, and I'm not a bone marrow transplanter. They allow me to walk past the room where bone marrow transplants is done, but they won't let me through the door. And that's best for the patients. It's really how you match up on certain markers of, just like you have to cross-match blood to get a good blood transfusion, markers that allow you to be compatible. And to some degree, gender plays into that, but these so-called HLA antigens even more. So you know, that has been the issue. In many diseases with bone marrow transplant, it's quite unusual that the marrow doesn't take. But in sickle cell, we try to do a milder form of transplant where the chances of rejecting the transplanted marrow are a little bit higher. So I expect that's what happened in that case. But the only point I want to make is that it's not that there isn't a way to get rid of the sickle hemoglobin in a patient. The problem is very few patients really are in a position to benefit from that, and there are very few providers who are able to provide that care, and even under the best of circumstances, you're trading an awfully high mortality for a disease that with reasonable treatment can last for decades of life. Not great quality of life, but better than being dead. At least most patients tell us that. So the other approach is, can we use the rapidly developing fields of molecular genetics and molecular biology to actually make a gene, that give the gene to the patient to cure the disease, so-called gene therapy. And that's where we come in, the Cure Sickle Cell Initiative. Our focus is quite narrow in the world of clinical trials and of efforts to improve the lives of sickle cell. We're not engaged in doing clinical trials on pain and implementation, the kind of implementation science that Dr. Hoots talked about, but really to have a very narrow focus on trying to make sure that these therapies get developed and then as the next step, get disseminated so that they're widely available to patients. Now, to do gene therapy with today's technology, not quite as heroic as doing the bone marrow transplant of what we just talked about, but you do have to remove the blood stem cells from a patient, at least enough of them, and then you have to insert into those cells the corrective gene, either one that promotes fetal hemoglobin synthesis or one that puts in a replacement gene, as I talked about. And then you recover those stem cells and you put them back in the patient. So they're not getting foreign bone marrow, so you don't have some of the problems that we were just talking about. But it is a very elaborate procedure. You do need to knock down the person's own bone marrow, so it requires a prolonged hospitalization. It is a bone marrow transplant, except with your own cells, so-called autologous, instead of the other. So you get rid of some of the problems, but you still have a highly complex, highly expensive, highly specialized therapy available right now in only a few centers. And I think Dr. Hoots would agree with me to say, if you look at the match of where those centers are and where the majority of sickle cell patients are, it's not a great match. So in fact, in many of the places where there are gene therapy trials going on right now, they're going to run out of patients who can participate in trials. So one of our jobs is going to be to create collaborations with organizations and provider groups and institutions like here that have a large numbers of patients who might want to participate in those trials. So let me finish then by telling you this. I do think it's time to rewrite the story. 70 years, there have been so many wonderful advances in molecular medicine. And in a way, having worked in the globin field, they were the first human genes cloned. They were the first human genes that we understood how they were regulated. They're the first genes that we were able to transplant in different kinds of cells, in different kinds of animal studies. When I was starting out in the hemoglobin at the Yale faculty, everybody was looking to get 1% of my effort because we knew how to clone genes. And so hemophilia. cystic fibrosis, Huntington's chorea, everything that we know about so many diseases is really built on the backs of people with hemoglobinopathy, sickle cell and thalassemia. So I've said it's time to pay back, time for us to pay back and get this kind of a curative therapy accomplished and out there. And that's really what this initiative is about. One quick last thing I'll tell you in preparation for this. I only have a couple of slides, so don't worry. We'll get done before supper. Is that the director of the NIH, who was a major impetus about creating this initiative, is famous for cloning the cystic fibrosis gene, and now there are drugs out there to treat cystic fibrosis, and they're proving to be reasonably effective. Francis Collins, his first important papers were studies of hemoglobin disorders. He began as a hemoglobin guy. So this means a lot to him. He's like me from those early days, feels the frustration that you all can feel even more deeply, and have a right to expect that we finally deliver on the promises of molecular medicine that flowed out of the original studies, the original diseases that were understood that were all hemoglobin diseases. Many other patients have benefited from this. It's time for us to deliver to patients with sickle cell. So what is this? This initiative is funded through the NHLBI. It was launched last September. And the idea is to accelerate the development of these treatments, as I said, and be able to leverage resources, engage the community, of all of the different kinds of stakeholders, as you see, to get on the path to cure. Now, what makes it different from what Dr. Hoots talked about? He said that we were talking about. How many of you in here have heard about DARPA? DARPA. Yeah. DARPA was created as a quasi-governmental initiative where there was government funding, but it was set up in an entity which sat like with 1 foot in the government, or I like to say 3 toes in the government and 7 toes outside the government, so that you could do things more flexibly under the auspices of the governmental organization. So DARPA was founded through the Department of Defense. It created, in effect, an outsourced entity with funding flowing from the Department of Defense, but having an authority from the government called the Other Transactional Authority that allows them to interact, for example, with for-profit companies. The government agencies are very limited in what they can do with a for-profit company, and to use government funds for that purpose. So DARPA is the reason, one of the major reasons why we have the internet. That's their famous thing, is for the development of a usable internet, not just the original technology that allowed computers to communicate with each other over a distance, but actually usable technology that, is now in these things. So that's DARPA. So this is meant to have some of the sort of shadow of DARPA. That we work with a clinical research organization called EMIS. My role as executive director of this initiative is I'm not a federal employee. I'm still a Dana-Farber faculty member, a Harvard Medical School faculty member, but I work on a contract basis through EMIS and through EMIS to the heart and lung. And we organize a set of executive committees and all the kinds of administrative structures you think, where we partner with Keith Hoots, Tracy Mondoro in particular, at the Heart and Lung Institute. They're all part of this executive committee. So I'll call it quasi-governmental, or however you want it. The idea is we can be more flexible. We can interact directly with patient advocacy organizations in ways that are just more difficult to do within the traditional funding structures. We don't have to work strictly through the long processes of contracts and grants, which are basically 2 major mechanisms by which NIH can fund research. So using that we can do 2 major things. One is use the expanded convening power. Second, uses some expanded funding power to target those things that we are learning from the convening power, the major gaps and obstacles to using a widespread application of gene therapy on the one hand, and on the other hand, to accelerate the technology development, sometimes very practical, on-the-ground infantry type of, you can call it research or call it development, the kinds of things that NIH traditionally, which focuses more on hypothesis-driven research, can't do so easily. So that allows us to work with all these many different, and remarkably enough, one of the things that the NIH has limited abilities to do is interact with other government agencies, like CMS and like the FDA. It's not that there's no interaction. There are actually some very nice interactions, but to work in a fuller and deeper way across those, to sort of say to the FDA, okay, these trials are coming down the pike. Let's find out in advance what it's going to take for you to approve them so they can be put into clinical practice. We can go to CMS and say, okay, whether or not insurance pays for this depends a lot on whether or not Medicare and Medicaid will pay for this. What do we need to do to convince you that these potentially very expensive therapies should be covered by Medicare and Medicaid? And then private insurers usually will follow suit. So those are the kinds of things that we can do far more easily and flexibly than can be done within the walls, if you will, of a federal agency. Am I going to jail for anything I'm going to say so far? Thank you. I'm going to make sure the plane takes off with me in it tonight. And of course we can work with other universities, with other advocacy groups. You see many of their logos up there, with organizations that do private foundation funding, like the Doris Duke, Foundation. So that's really how the reason that we were put here, that to do some things that would be much harder for NIH to do on its own in the world of practical delivery of this therapy to large numbers of patients. So we fill the gaps. We're not in any way taking away from the traditional NIH focus on sickle cell. So the amount of NIH money that's going to sickle cell research and the clinical trials that are being sponsored and so forth will stay the same. We hope it'll actually expand a bit as a result of the impetus that we can give by the progress that we make. So this is a different pot of money that is being added to the effort to cure sickle cell disease. And as I said, we are there to facilitate. We don't do the research. We facilitate it, we convene, and then we look for more agile ways to fund things we find worthy and important of doing, even if they wouldn't necessarily come together to make a nice NIH grant. Like somebody already has, say, a good delivery mechanism for a gene therapy agent, but they need to make 1,000 times as much beyond what they could make on their grant. That wouldn't be easily funded at NIH, but we can fund it through the consortium, just to give you one example. So the work we've done in the months since we started have been to find some priority activities. You've heard many of them. We've heard many of the same messages from the patient community, from the advocacy community, and from providers about why people who might be very anxious to be on a clinical trial are just finding it very difficult to do that. And we're looking at things like the geographic issues of the mismatch between where the centers are doing the research and where the patients are, and how we might find ways to assist patients to be on that. Keith mentioned that we do need a harmonized data collection system so that we can accumulate the data. We're funding an economic analysis to prove that this therapy will be clearly beneficial in human terms and in clinical terms, but also beneficial economically, so that the initial high cost of a single therapy we can prove over time will actually save the health system money. We know now that care of a sickle cell patient in adult life, which can go on 10, 20, 30, 40 years, is over $100,000 a year, and probably that's a modest estimate. So it doesn't take too many years to say that this will save the system money, and more importantly, will save a lot of suffering. So we've formed a memorandum of understanding already with the American Society of Hematology, which has a major sickle cell initiative. And of course, where most people providing hematology care to sickle cell patients are members, so that it gives us connection to provider community who don't work in academic institutions, which is a mechanism we needed to create. And with the California Institute of Regenerative Medicine, the so-called Stem Cell Institute out there, we are going to co-fund projects. They have to be California-based investigators, but that is a pretty big state. They've got some very good investigators. We've already approved on the last step of approving funding for one major project out there. We've just released request for applications. Oh, wait, I can't call it that. What's an ROA? Request of application? Request opportunity. So that we want, for example, better information on how do we prove to the FDA or to a payer that these gene therapies are achieving the clinical goals that you want, that are achieving hematologic correction of the patient, hemoglobin phenotype, for example. So they call those endpoints and assays to get to the endpoints. Those are all going to be necessary, not in these initial phase trials, which are already underway, so-called phase 1 and early phase 2 trials, which treat a handful of patients. But when we get to this, the phase 3 trial that you have to get through to get FDA approval, then you need to have that endpoints and assays. And so this is just a list of some of the projects that we've already decided that we will fund if we can find the right kinds of proposals. And we have a website here. I'll leave these slides with you for anybody who wants to get the website to find out how to access this thing. We ask for relatively short initial applications, just a 2 or 3 pager, kind of a concept or paper, and then based on how well it fits with our priority set, we would ask for something a little more detailed. But it's far simpler than applying for a traditional NIH grant. At least that's what we hope it will be. So as I said, there is eligibility here that's a bit broader than through the traditional funding mechanisms, and we've gotten some from higher education institutions. We've gotten some from nonprofits. The companies are saying they don't want money from us. They want the economic analysis. They want assays and endpoints that we help to fund, so they'll benefit indirectly from that. So please add your voice to ours. We're hoping that within the next couple of years, you will see FDA approval of gene therapy trials for sickle cell anemia. In Europe, gene therapy for a closely related set of conditions called the thalassemia syndromes has just happened. And I think that's going to lower some of the barriers to getting it approved for sickle cell anemia, because many of the technologies behind it and the therapeutic maneuvers behind it are quite similar. The patients are different, and so we're anticipating some different challenges there. But I'm optimistic that gene therapy will be approved within less than half a decade. But I'm finding a much bigger challenge in thinking about how we get that therapy to everybody. But the history of when something becomes a technological problem is that the technology gets simpler and cheaper and more accessible, and that's what we hope we can help foster. So I appreciate your attention and my stroll down memory lane, and thank you very, very much.
So thank you so much for that, Dr. Benz. Now, today, of course, is World Sickle Cell Day. And so what we're trying to do is shine a light on sickle cell disease and have our Shine a Light campaign. So at the front, they were handing out little candles. So what we want to do right now is to shine a light on sickle cell. The Global Assembly of the United Nations passed the regulation designation June 19th as World Sickle Cell Awareness Day to be held annually starting in 2009. Since then, It has served to help increase public knowledge and raise awareness of this worldwide public health concern and the struggles that those with sickle cell disease and their families go through. The resolution, initially sponsored by the Congo, has helped to elevate awareness of sickle cell disease as a serious public health concern affecting more than 100 million people around the world. This year, sickle cell disease community-based organizations and others are organizing gatherings across the nation to help shine the light on sickle cell disease while celebrating the 10th anniversary of World Sickle Cell Awareness Day. Howard University Center for Sickle Cell Disease, together with communities across the nation and around the world, are standing up and speaking out to increase awareness, build supporting networks, raise critical resources, and strengthen our collective resolve to advocate for access to sickle cell services and a cure for sickle cell disease. So let's all shine a light on sickle cell disease. Let's take a moment of silence just to give to individuals living around the world with this terrible disease. Thank you. So the next part of our program is we're going to have a panel of individuals that are living in the sickle cell community to discuss their experiences with sickle cell disease. So I will now invite forward to the table the panel. Okay, so the panel members that are coming forward, we have Tisha Samuels. Tisha Samuels was born in Washington, D.C. and raised in Prince George's County. She is a product of PG County school system where she was homeschooled from middle school through high school. From there, she went on to attend Test College, where she received her medical assistance certification. She is very active in her community, serving in the DMV area. She is a member of Mount Moriah Baptist Church, located in Washington, D.C., and serves as their dance minister. Tisha is grateful that she has been able to accomplish and participate in things despite suffering from sickle cell disease. She is excited that her participation in a clinical trial has given her a chance to do so much more. Things that are delightful in her personal life, and she loves to share her personal experience with and give glory to God. She has been married for 11 years to her husband, John Samuels, and is devoted to her daughter, a godmother, and her friends. We also have Nene Kalu. She has been serving as a social worker for the Howard County sickle cell community for over 8 years. It has been her honor to work with the sickle cell community, sickle cell patients, their families, and providers in caring for individuals with sickle cell disease. While writing a paper in her graduate classes, she became intrigued and wanted to learn more about sickle cell disease. This has led to her current role as a social worker for the Sickle Cell Center here at Howard University, and it has been a continuing learning experience for her. And lastly, but definitely not least, is Jacqueline Hammond. Jacqueline Hammond is a theater educator at Bowie State University. She is also a parent of a son who recently succumbed to the effects of sickle cell disease. As a sickle cell survivor, she is now focused on advocating for improved care of those who live with the condition, funding for research, and courseworking towards a cure. She has served on Howard County University Hospital's Participants Advocacy Board for over 2 years, and she may not be joining us today.
She had to leave, had a family emergency.
Okay. Okay. So we're going to go ahead and ask you to quickly give us a presentation. Because we are running low on time, if you could just keep your presentation shorter.
My name is Tisha Samuels. I'm 37 years old. Sorry about that. I received a gene therapy transplant through MHLBI. Here at Howard. And on the flip side of that, because I'm part of the team who care for the sickle cell patients, so I work with patients who need blood transfusions, to everything, to transportation, to food, and just having emotional support, because from what I've seen, I'm working with sickle cell patients, it's a very debilitating disease, and it affects every area of their life. So to be a part of a team to actually help care for sickle cell patients and see them reach their potential has been a great honor for me.
I would like to invite the panelists up here and open it up for a couple of questions because there's another event coming up. Any questions?
This is for Dr. Bennings and Dr. Hoots. As a hematologist and pediatrician now in private practice, with opioid crisis, what is the NHMEA doing for the sickle cell patients? Because the problem is, patients need pain medicine to survive, and they've been on it for a long time. There's legislation going on right now that's not include sickle cell disease, and those that the pharmacy can talk to the patient, talk to the primary caregiver, and okay the medication. Every day I'm invaded with phone calls, not once for that one prescription, but about 5 times in a day, just to okay medication the patient has been taking since they were little, so that they can survive, control their pain, and be able to go to work. So what is NHRBA doing about it?
I can honestly say that we're obviously, our mandate, let me go back to that, I'll finish with that. The word is starting to get there, okay? I mean, it's, yesterday I got an email from Secretary Azar and Admiral Girard, who's the, Secretary Azar is the head of HHS. Our agency, NIH is part of that. And Dr. Girard is the Assistant Secretary of Health. Using information from across HHS, including NIH, CDC, and CMS, acknowledging what you just said, that there is a huge problem out there, and that you can't stigmatize patients. And that they explicitly said sickle cell, but they also mentioned cancer and one other entity, but there were only 3 indicated. So I think people are starting to get the message at very high levels that this is a real problem. I think that's why we certainly, as I said on the implementation side, we know what a big problem that is, and we're working and we're dialoguing a lot with the recommendations came from the Center for Disease Control, and from the beginning have been the feedback to them across from both the private sector, like the American Society of Hematology, and the public sector, all other branches of HHS and others, has been that one size cannot fit all. That sickle cell is indeed a special issue. Cancer might be its own special issue, but that's a more acute problem, whereas in sickle cell it's a chronic problem. So I wish I could give you the absolute answer that this ain't gonna happen again, but I can't. But I think at least for the first time I've noticed since the new CDC guidelines went out in response to the opioid epidemic, people are starting to hear the pushback that says, you can't, and by the way, that actual CDC message excluded sickle cell, but it didn't get translated. And so part of this is obviously a public information and educational campaign. So I think that's probably the answer. I mean, we're not going to solve the pain issue, even with cure sickle cell, before this has to be dealt with. So that's the answer. It's got to be educated across the whole U.S. healthcare system for that problem that you deal with 5 times a day to be solved.
Yeah, I just might add a couple thoughts. You know, one of the challenges is that the National Institutes of Health, including the National Heart, Lung, and Blood Institute, even our initiative, are mandated, and our authorities are somewhat restricted to research and the development of these treatments. Much of what you described, we can help by, as Keith said, making those agencies that are more responsible for the delivery of care aware from our research information of what the issues are and how they should be thinking about the policy. But I think someone who needs to hear from you and hear
the challenges you just described, the American Society of Hematology Sickle Cell Initiative, they have many more degrees of freedom to get in the face of the regulators, to get these into the care guidelines, which are being picked up by providers in emergency rooms, etc., to be sure that the information in there, from your point of view, is as effective as it can be on the ground, because they're closer to where the care is delivered than, in a sense, we're allowed to be.
I have a son with sickle cell, and my question is, what's the horizon for a sickle cell person with SC? Because a lot of these treatments don't include a person with SC. You know, so is there anything coming down the pipe where in the future for a person with SC, sickle cell disease?
Yeah, I can't comment on who's participating in all of the early gene therapy trials, but there's no reason why a patient with SC disease couldn't receive that kind of therapy. I think when people do clinical trials, they try to idealize the patient population so that there's as little heterogeneity in the patients as possible so they can get a clear result, but these therapies should work in a patient with hemoglobin SC disease. I'm not sure that it'd be as easy to get on the first phase of the clinical trial. So, but it's always worth checking with the investigators to do that. Keith, maybe you know more. I do know that this is not just totally below the radar. We are one of the biggest amount of non-cure sickle cell dollars that we spend are for investigator-initiated research. And I can't specifically talk about grants that come from outside, but I do know that there are people who are asking your question, and that's probably a relatively newer phenomenon. So I think, and I agree with everything Ed said, but I think hopefully as we go forward and get more information that's applicable across all hemoglobinopathies, that we will have the resources and the means to subdivide appropriately for the investigations and the education that need to be tailored more to a subset as opposed to the broader group. I hope that helps. But I think we're starting to get there. We aren't there yet, but we're starting to get there.
I know we have about 24 students part of the Howard University Healthcare Summer Project here, reporters, and I know they wanted to ask you a question because they're working on a story about this.
Hi, I'm Madeline Bode. My question for Ms. Samuels, I was wondering if or how having sickle cell has affected your mental health.
To answer your question, I think I realized the effects that it had on my mental health post-transplant, because when you are living with a debilitating disease for so many years, it does take an effect on your psyche because you are just struggling to survive. I was able to work. I attended Howard University for 1 year, but then I had to withdraw because I was so sick. So I think once I, 1 year out of post-transplant, now I'm trying to figure out who am I without sickle cell, and that needs to be addressed as well, because when you are in pain for so long and then all of a sudden you pray for to not have as much pain or to be able to do the things that you always wanted to do, and now you've given that opportunity. You have to take a step back and say, okay, who am I? My friends know me as the sick one. My family has always had to take care of me, but now I'm independent. So I would think that's been the effect on my mental health.
I just wanted to add a thought for that, is that mental health, thought of as things that affect you psychically, is only part of the challenge for sickle cell patients. There's increasing evidence coming out now that even in patients who have never had the sort of classical strokes or so-called mini or micro infarcts of the brain, that there are effects of brain health in sickle cell. Even when people don't seem to be having symptoms, that you can pick up abnormalities in blood flow to different parts of the brain. So it is a double challenge. There's the psychic challenge, and it's called what you will, more the neurological or organic challenge, and that these affect all parts of the brain, including your executive functions.
Can I just, two quick seconds, it's actually triple threat, right? Because there's some evidence to suggest that emotional or psychic stress as well creates pressure on the system, leads to some of the downstream effects in sickle cell. So it kind of gets you on both ends, if you would, your emotional health and well-being, your physical or brain health, but it gets you at the front end as well in terms of stress and other mental issues impacting your disease.
Yeah, that's a great point. Stress is a major trigger for sickle cell crises.
Speak loud enough, but it's okay. For Ms. Mimi, are there any programs in place to address what she just said, that she's now moving into another identity because she's had some effective treatments and she's no longer the sick friend, the sick daughter, the sick neighbor, but now the healing and coming together neighbor, healing and coming together daughter. Are there programs that you all have in place?
So that's a developing area because, as you know, not all sickle cell patients are eligible for transplant. And you're finding your new identity as a transplant patient. A lot of the programs out there are usually for sickle cell patients who have the disease, like support services. So I think that's an area that needs to grow. As more sickle cell patients are exposed to transplant and learn more about what transplant gives, the pros and the cons, then more groups, especially support groups that support your identity as a person after transplant needs to happen.
Any ideas on the books that you are cooking, like music therapy, art therapy?
Well, those already exist.
Okay.
So to kind of combine those recurrent support systems is something that needs to be looked into. There are a lot of groups online. You can check Facebook and other services, and even programs in different states do have groups that specify or go towards clients who have transplant. So when you look at those, and especially for our younger generation who loves social media, that's one avenue for them to go and kind of voice their opinion and kind of express themselves. So that's one good place to look for it.
Just one more question.
Thank you. My name is Sheila Tyson. I live here in D.C. My cousin came from New York because I asked her to be 70. She's kind of shy. I guess one of the questions we want to know is the clinical trial. She didn't know anything about it, didn't know anything about the medication. Brenda has suffered with this since she was before 12. And the pills that the doctor prescribes for her, what is it, Octipine? Yeah, 4 times a day that she doesn't take. And she just had the prices last week. So I asked her to come because I wanted her to get more information about sickle cell, because she really does suffer a lot. So anything you can do to help her. And she's in New York. So is there, where in New York and Westbury, New York? Somebody that's in Long Island.
So I'm glad that you asked the question on a few levels. First of all, it's not easy to find clinical trials, so don't think that you've been missing something. There are a few places that you can go to see trials that are going on anywhere. Clinicaltrials.gov is a site that's kind of managed by the NIH that has trials for everything. When you go on that site, you'll type in sickle cell, and it'll pull up all of the trials that are going on. You'll be just right for some and not at all right for others. And it will also tell you, if you click into each of those, it'll tell you where the various sites are, or if there's a single number, it'll tell you a number or a website to go to for that trial. Now, sometimes it's very difficult to navigate that. I won't tell you it's not. At gethealthystayhealthy.com, another website, gethealthystayhealthy.com. There's some information about sickle cell in general, and at the bottom of that will be a place that you can go to look for sickle cell trials. Some, it won't be all of them, like clinicaltrials.gov. And then, last but not least, talk to your doctor and specifically say that you are interested in a clinical trial. Many doctors' offices may know about them, but if they don't think that you're interested or they're not sure, then they wouldn't raise them. But when you are talking to your doctor, let them know, and they might be able to help you or to refer you to someone in your area that's active in clinical trials. I'm sorry.
Last one.
It's clinical, the whole word clinical trials.
Thank you. My question, I'm sorry, I have a strong accent, so I'll try my best. My question will mostly for Dr. Hoots, I believe, I'm sorry. I'm from the Congo. We talk a lot about the Congo, about the NIH working in Africa. And I'm so happy with all the clinicals, everything that we do for this. Okay. Everything that we do for the sickle cell. My only concern is everything is being done. It's so high tech. A lot of African countries, they're not equipped to even implement some of the treatment. Even just the hydroxyurea you're talking about, it's very expensive. I myself, I have a foundation. I mean, a lot of people can afford it because of the cost and all of that. So how are we planning to help those countries who have the highest concentration of sickle cell patients to actually benefit from all of this innovation that's happening, the gene therapy, all, I mean, the Congo one, I'm coming from the Congo Kinshasa, not the Congo that started there's two Congo in Africa, the Kinshasa one. Our sickle cell clinic most of the time doesn't have electricity. So how can they do a gene therapy or bone marrow transplant? So I'm just happily planning on doing that.
It's an extraordinarily good question, and it's one I actually know a little bit more than I can say, but not a lot, because it's still in the very much discussion phase. But there are efforts ongoing to answer your last question. It's like, how can you turn what Dr. Benz talked about into something that's applicable in remote places where the resources are limited? That's going to take some time. It's going to take also proof here in the U.S. and in Europe that it's safe. We would never take, we would hopefully never take anything that was unsafe anywhere to a resource challenged area. But at the same time, we have to solve the technical side. We have to solve the part that makes it prohibitively expensive first here, but then there. And we are thinking about that, and there are organizations of notable resources that are exploring just that. That's all I can say now, because it's way too premature, because nothing has been pledged, so I can't talk about it. But it is being thought about. But in the meantime, what we're trying to do is build the infrastructure, and that hydroxyurea study is using donated hydroxyurea from big pharmaceutical company to treat those patients on trial. So at the same time we're looking down the road to curative strategies, people are using these infrastructure bills that I was talking about, are trying to build partnerships with things that we know work, like hydroxyurea, and get entities that are altruistic in their focus and say, okay, if we pay to get this trial going, will you provide the drug? I mean, it's not that we wouldn't, but we can do a lot more patients if we split the cost. So that's kind of the strategy in the near term. The longer term strategy is not that no one is thinking about it, it's just that there's so many hurdles that have to be overcome before it's even realistic to talk about it to an audience like this.
Can I address her question, please?
Yes.
Yeah, I think we have to.
I want to address her comment.
Very quickly.
So in Africa, there's an African group now of hematologists, and they're working towards that. So we meet every year, regional overall, and then each region also meet with the hematologists and the oncologists. So there's Society of African Hematologists and Oncologists. So for every hydroxyurea is available in the pharmacy, but in the remote areas it's not. So for Kinshasa, you have to check with your with the city and see who the universities are. The universities over there, the hematologists have access to those things. So encourage those people to go to the teaching hospital, and that's how they can get the treatment. Then from there, then it trickles down to the villages.
Oh, I'm in
Yeah, Kinshasa, yeah. So the university should have someone contact first.
So how do people know? Because
Yeah, I think we have to finish. We actually work also with Leon Cimolo. He's in Kinshasa, so we met him last year. We went to Congo. So I'm supporting my Congo short, which I got over there in Brazil, but we met people from Brazil, from Kinshasa. So we're actually trying to help raise money also for Congo as well. I'd like to thank our panelists, wonderful presentations, and we can I also would like to remind you that please fill out the feedback form, evaluation form, because it's very important for us to continue with this conference. I also would like to mention our sponsors. So we have to thank Be the Match, this is one Memorial Registry, and as Karen specifically would like to thank Howard University Department of Pediatrics, Dr. Rana, Betty Houston, and Cynthia Gibson. We would like to thank community-based organizations, Veterans Sickle Cell Center Organization, Sickle Cell Association for National Capital, and Face of Our Children, who are our very close friends here at Howard. We'd like to thank our big sponsors, Novartis, DC Office of the People's Council, Walgreens, and we also like to recognize our staff. If you can please stand up, and so we can thank you as well. Angela Mason, I think she is our champion for this conference, and she's been very Great. With this, thank you so much, and please come next year. So I hope to continue this tradition here, this conference next year. Thanks so much.
Now, if you help us to vacate the room very quickly because there's another agenda.
Very nice to hear you talk. That was fabulous.
Actually, I have a question.
question for you. I think we have to clear the room. What question is this?
Just if I